Hello, and thank you for joining the Center for Financial Security for Nursing Home Care and the Impact of an ACA Program, a webinar overview of study findings and implications. My name is Hallie Leinhart. I am the Assistant Director of the Center for Financial Security here at the University of Wisconsin-Madison. To give just a bit of a rundown on our format today, we will start with the research background, methodology, and findings, and then we'll move into discussions of study findings and implications more broadly. We will then continue with a question and answer session, so please feel free to submit questions in the chat box located at the side of your screen throughout the webinar. I'm very excited to introduce our presenters for today's webinar. Mary Hammond will be presenting on research that she and her colleagues, who will join us later for the Q&A portion, conducted under the Center for Financial Security's Retirement and Disability Research Center. Mary is an associate professor of economics at the University of Wisconsin-La Crosse. Helen Levy is a research professor at the University of Michigan, and Helen has joined us as a discussant today. Patty Colin is the president and CEO of Care Providers of Minnesota, and Patty has also joined us as a discussant today. Thank you all for being here. And with that, we will get started, and I will turn it over to Mary.
All right, Hallie, thank you so much for that introduction, and thank you all for participating today. We're really excited to share the work that myself, Brooke, and Danny have been working on over this past year. I want to especially thank our discussants today who are going to provide some helpful feedback, and we welcome any comments or questions on this work. All three of us hope that this is going to be the first project in a longer stream of research, so any ideas or suggestions are definitely welcome, especially those of you who work in the industry and might share some unique perspective that us as researchers would benefit from. So before I get going into the research itself, I also want to say thank you and acknowledge the support that we've received from the Social Security Administration through the Center for Financial Security Retirement Research Data Center, as Hallie mentioned. And Hallie, it looks like perhaps I will need your help with slide control here. I'm getting a little bit of a lag. If you could please help me advance slides, that'd be great. Excellent, thank you. So we have a very long disclaimer coming up, but it is important that we emphasize that this work is solely our own. This is objectively conducted research. Any sorts of opinions or inaccuracies in the research we take full responsibility for as researchers. Okay, it looks like we're catching up there a bit. Hallie, if you could grab slide for me again, please. So I'm going to start by just sharing some facts about long-term care that I'm guessing many of us are fairly familiar with. And the first slide that should be appearing for you in just a moment is displaying some of the costs of long-term care. And I'm sure that it comes as no surprise that long-term care is very expensive. And this is just a simple bar chart from Kaiser Family Foundation, where we're showing the costs of care across different settings. Nursing home facility care can cost as much as $91,000 per year. And as you can imagine, this quickly exhausts most families' resources. There are other forms of care out in the community that may be less expensive, but as we all know, we're not exactly comparing apples to apples here. The point that I want us to take away, though, is that perhaps the care setting might have important implications for costs. Slide, please, for me, Hallie. Now, when I just spoke about costs on that slide, what I'm getting into are the costs for Medicaid, if we think about publicly funding those programs, or for individual families themselves. But because those costs are so high, they quickly exhaust the resources that families have. Medicaid does become the primary payer, but there is a policy interaction here that motivated our interest in this topic, and that's a policy interaction between Medicaid and Social Security. So, as individuals are living in nursing homes, Medicaid covers the cost of room and board. But as we'll see on this next slide, what we see when we look at the cost to Social Security Administration are a little bit different, and that's because of the Supplemental Security Income Program. So SSI provides income support to low-income households, and the payments depend a bit on where one lives and who one lives with. So what we're showing you here in this table are supplemental security income benefits that individuals might receive, both currently as of 2019 as well as of 2011, which is the starting point for the program that we're going to be studying in this research. As you can see, when people live in a nursing home, the maximum benefit that they might receive is fairly low, only $30 for a single, $60 for a married person or married couple. Now, that's low simply because Medicaid is paying for room and board expenses when one lives in a nursing home. And so the residual expenses that one might have are expected to be quite low. Now, if someone moves out into the community but is living with, for example, their adult children, the maximum benefit that they might receive could be a bit higher, about $449 per month in 2011 for a single person. And that has gone up just a bit. As of 2019, it would have been $514. That's the maximum benefit amount that someone might receive if they were helping to pay for room and board expenses. Or excuse me, in that case, if they were not paying for room and board expenses. If they were paying for room and board expenses, and especially if they were living on their own independently, we move up to the top row in each set, that independent living amount would be the largest benefit that one would receive through supplemental security income. So I hope from this table we can see that where you live matters for supplemental security income. And then there's a logical link between any sort of policy or program that might influence where people live. And that's really the connection that spurred our interest in studying both this Medicaid program as well as the impact on supplemental security income together jointly in the project. Slide please for me, Hallie. So what we then want to begin motivating is how we think these programs might be interacted. And we're going to look at one particular program that influenced Medicaid coverage of home and community-based care, and that was the Balancing Incentives Program, or BIP. This program was part of the Affordable Care Act, and it's one in a very long stream of programs that have tried to incentivize states to spend more money on care outside of institutional settings. So as you might imagine, looking at those comparisons of costs, one could assume that perhaps it would be cheaper to provide care for our older adult community if they remain living in the community as long as they are physically able to do so. So this particular program, the BIP, authorized $3 billion for states to spend between 2011 and 2015. And this is federal matching assistance money. So for each dollar that the states were spending of their own Medicaid monies, they could draw down more federal assistance to support their home and community-based expenditures. Now, not all states were eligible for this program. The only ones that were eligible were those that, as of 2009, were spending less than 50% of their total long-term care dollars. So that includes nursing home care. They spent less than 50% of those monies on care out in the community. So essentially, they were targeting these states that needed to catch up and begin shifting more of their Medicaid expenditures to community-based settings and away from nursing homes. One state was eligible for a 5 percentage point increase in their FMAP rate, that was Mississippi, and the remaining states were eligible for a 2-point increase. Based on that 50% threshold, there were 38 eligible states, 21 were approved to participate, 18 continued participating through May of 2015, and in our study, we're going to be focusing on the 15 of those 18 states that chose to devote some of their BIP funding towards older adults. So just to be clear, the BIP could have supported community-based living for persons of any age, including children and adults with care needs. The focus of our study is going to be on older adults, persons age 65 and older. Slide please, Hallie. So what I'm showing you here then provides a highlighted map of those 15 states that I've mentioned on the prior slide. I see on your end that is still just coming up. But as the map arrives, you're going to see that these states are distributed throughout the country. They're not just from one particular region, although we do have fewer out west than what we have on the eastern seaboard. But they don't tend to be necessarily from any one particular region. And on the next slide, what I'm going to show you as well is that they fall on all different places in the FMAP range. So again, FMAP is the federal matching assistance percentage. And I'm showing that to you by looking at the x-axis. We have the dollar amount that the state would receive for each dollar of Medicaid spending that they commit, they would receive this dollar amount in matching funds from the federal government. So I know many of our listeners are probably very familiar with FMAP. The point that I'm trying to make here is that it wasn't just the states that receive a lot of assistance from the federal government that were eligible here. We had states in that category like Mississippi and Arkansas, but then there were also states like New Hampshire, New Jersey, and New York who also were eligible and chose to participate in the program. So it's a fairly diverse group of states. Slide, please. Here now I'm showing you the way in which the BIP funding that the states received influenced their total multiplier. So on the prior slide, the amount that Mississippi would have received for any Medicaid spending would have been about $3 in federal funds for every dollar of state funding. But now what I'm showing you is from Mississippi. With the BIP, they receive almost an additional $1 from the federal government for any of their long-term care spending during the program performance period. So from the time they were approved up through the end of the BIP program. Other states received smaller amounts, and that's a function of that percentage point difference. Mississippi got a 5 percentage point increase. Other states received a 2 percentage point increase. Now, what we know from prior research, former studies have looked at whether or not expenditures actually increase. So on the next slide, I'm going to show you a graphical summary from prior research. And what we're going to see is comparing non-participating states to participating states. We have an increase in the amount of spending out in the community that was faster in our participating states and was nearly flat in our non-participating states. Meanwhile, in our non-participating BIP states, their expenditures on institutional care increased quite a lot faster than what they did in the participating states. So from prior research, it looks like the spending moved in the directions that the program was desiring. The question is, and what we want to answer, is whether or not BIP actually moved people from institutional care and out into the community. So on the next slide, I'm clearly articulating for you the questions that we will try and contribute to this research in our study. We want to determine whether or not BIP moved people from nursing home settings out into community care settings, or if it potentially prevented moves into institutionalized care in the first place. Now, if it did contribute to these sorts of moves, it might also have an impact on supplemental security program funding, because as we saw earlier in that table, where you live determines your maximum eligibility for SSI payments. So on the next slide, I'm showing you the two hypotheses that our research will focus on testing. We expect that BIP will reduce the share of older adults who are living in institutional settings. And if it does this, BIP should also then increase the share who are receiving supplemental security income. Now, we're also going to look at a few other outcomes, which I'll define for you in a few moments, but the big picture is really captured by these two hypotheses. On the next slide now, I'm sharing with you some information about the data that we're going to use. So our data come from the American Community Survey, the ACS, and as I mentioned earlier, we're restricting our focus only to adults who are age 65 and older. We're looking at years prior to when the program began, so looking at 2006, going all the way up through the end date of the program, which was 2015, and the extension years that some states kept using their funds during. So we get all the way up through the end of 2017. And then we're comparing only our treatment and our control group states. We have about 400 million observations in total. And on this next slide, I'm defining for you what I mean by treatment and control group states. So as you'll see on the map, the states that are highlighted in yellow are the same 15 states that I showed you earlier. These are our states that participated in BIP and also directed some of their efforts at services for older adults. The states now that I'm highlighting in gray are the states who are ineligible to participate in the BIP. We're leaving out of our main models the states that were eligible to participate in BIP but chose not to do so. And we're doing this because we think that there might be some reasons not observable to the researchers why those states would have chosen not to participate. And therefore, we think the cleanest control group in this case would be our states in gray, those who were ineligible. Now, on the next slide, I'm also going to show you an additional piece of variation that contributes to our study. Not all of our BIP participating states began their program activities at the same time. So in the table, what I'm doing is listing for you our 15 states that we're focusing on, and I'm showing you the year in which their programs were approved. So we have approvals staggered over 3 years, over 2012, 2013, and 2014. And so both that cross-state and overtime variation will contribute to the estimates that we create in our empirical analysis. And on the next slide, I'm going to provide for you just a simple sort of thought experiment or example to articulate how this works. So let's say that those yellow states, my treatment group states, before the program, 8% of older adults lived in nursing homes. And let's say that in the gray states, my control group states, 4% lived in nursing homes. This would make sense because we knew that BIP eligible states are those that were spending less on home and community-based care to start. So if after then the BIP, as we click on through, we see a reduction in the share living in the nursing home in treatment group states of 5%, then it would look like the BIP had the intended effect. We would have a 3 percentage point reduction in my treatment group states. But we also want to pay attention to what was happening overall, what other sorts of trends or other things at the same time may have driven that reduction. And we'll use the control group to get a sense of that, what would have happened question. What would have happened in the treatment group if the BIP did not exist? So using those differences, post and pre for the treatment group and post and pre for the control group, we can see that we have a total difference of 3 percentage points for the treatment group and 1 percentage point for the control group. That would then lead to an overall difference in differences for the entire experiment of 2 percentage points. So this little 2x2 table then articulates what we'll be doing in a regression setting where we control for other factors that differ across these states. So as we move forward on the next slide, I want to show you then the other sorts of things that we'll be controlling for. On the right-hand side here, I'm listing all sorts of factors about the individuals who live in the states that we control for in the regression. So that includes demographic factors as well as socioeconomic factors like educational attainment and income. We're also controlling for whether or not individuals were born in the US because we know that cultural norms about cohabitating with your adult children may differ a lot among those who are more recent immigrants and those who have a longer history in the US. And then finally, the outcomes that we'll be looking at are not only institutional residence, like I mentioned, but we're also going to look at cohabiting with family, primarily adult children, whether or not people have moved in the last year. So if we're finding changes in these other two outcomes, we should be seeing changes in just the incidence of moves as well. We're also going to look at whether or not they receive any SSI and also the amount of SSI, though as I present those results, I'll note some limitations in that amount data in the ACS. So moving forward, I'm going to show you our main results here, and these results are analogous to what I was explaining in that simple 2x2 table. If we start on the left-hand side, that first coefficient on the BIP policy variable is 0.000, and what that literally means is that we found a 0 percentage point change in the rate of nursing home residents, and that's quite precisely estimated. The confidence interval is very tight, around 0 percentage points, which would suggest the BIP perhaps had no impact on the rate of institutional residents, or at least that it didn't change in those states relative to non-BIP states. For cohabiting, however, we did find a relative decline. So this would be a 0.6 percentage point decline in the rate of cohabiting with adult family members in BIP states relative to non-BIP states. Now, associated with that decline in cohabiting, we actually found an increase in the rate of moves. So that would suggest that it's not necessarily that adult children are moving into their parents' homes, but rather parents are moving in with the adult children, if we take those two estimates together. And that increase is of about 0.4 percentage points, so reasonably close in magnitude to what we found in cohabiting. Associated with these estimates, we also find an increase in the receipt of any SSI payments. of about 1/10 of a percentage point. And the amount of SSI received, this is annual amount in dollars, went up by about $235, $236 in BIP states over and above any increase in non-BIP states. So in total, it seems that the program may not have made a difference in institutional residence, but perhaps it was moving people from living independent, from cohabiting to living independently. But before we go in and explore that possibility, I want to pose an additional question on the next slide. And in this question, I'm asking how large an effect on institutional residence might have been reasonable. So let me summarize on the next slide briefly a study that helps us to answer this question about what effect size would have been reasonable. And this is a study by Moore et al. In 2007. And what they essentially did was use CMS data to try and estimate how many older adults who are either currently living in a nursing home and had been for some time, or who were in that current year moving into a nursing home. How many of the people in that population could have potentially been transitioned back out to the community? Because as we know, not everyone who lives in a nursing home has a level of care need that could be met in the community. Sometimes an institutional level of care is what's needed. So using their definitions, they create estimates at the state level of how many older adults are actually low care needs. And what we've done is we've taken their estimates and we've then produced an estimate of how large the population that this BIP program would have been able to move could be. And we're going to translate that so it's measured in the same way that our estimates are measured. It gives us some sense of how large a percentage point reduction BIP might have had if it had either moved the entire group of low care needs people out into the community, or if it had simply moved or deterred those who would have been flowing into the nursing home in that single year. So on the next slide, I'm going to graphically show you those two reference points. And I've labeled them for you as an upper bound, meaning the largest potential reduction in the nursing home population that we would have seen based on these Moore et al. Estimates. And that would have been moving both the long-term residents who we estimate as low care needs and those who are new residents back out into the community. Then there's the lower bound. This would have been then just deterring those current people who are flowing into the nursing home from going into the nursing home and instead maybe diverting their care to the community. What I'm overlaying here then are our estimates of any change in the nursing home population. The very top one, the dot is showing you that 0.000 from my table, as well as the confidence interval around it that I mentioned earlier, which is fairly tight. If we try again to estimate similar regressions using different data sets, the next set down is with the health and retirement study. We get less precise estimates because it is a smaller sample, but we can see here we also don't find any sort of reduction in nursing home residents that would be similar to what Moore et al. What their estimates would have suggested. The same is true if we use aggregate CMS data. We find a very small decrease, but it's nowhere near even our lower bound. Although it is slightly less precisely estimated, we can rule out it being as large as that upper bound reduction. And so on as we move through several other robustness checks that we talk about in the paper itself. So moving ahead then, as we flip it on its side, you can see just a little bit closer, there's nothing that approaches that lower bound. And then that brings us to a question. Why then did we find that SSI increased? So remember from my table, we found about 1/10 of a percentage point increase in the receipt of SSI. Why would we find that if we're not finding the change in institutionalization? Well, as shown in the table 2, we found that there was a reduction in cohabiting. And if I remind you from our first table, the relationship between cohabiting and SSI receipt, when you live with other family members and you're not paying room and board, your SSI benefits may be lower. And in fact, in that case, they may be so low that you are no longer eligible to receive any positive benefit because you earn too much money to earn any amount of that 514, for example, in 2019. But if you were to move back out independently, you could potentially become eligible for SSI because the maximum benefit level is now higher. If we move ahead, let me show you a similar picture on all of our robustness checks for cohabiting. You can see that across the ACS, that original estimate that I showed you is in fact negative. We find the same thing when we look at the HRS, although it's less precisely estimated. And when we use other assumptions about how to model this relationship that we discuss in the paper, we find pretty consistently that it looks like there was a relative decrease in the rates of cohabiting. Moving forward, we also find that there were increases in the rates of moving. So we don't think that this is necessarily people who are housing, for example, adult children maybe right after the recession or still as adult children are recovering from the economic recession. We do think that this is older adults who are in fact moving their own housing. And so that lends a little bit more credence to the story that this may be related to the BIP policy. Now, on the next slide, I just show you overall the changes that are occurring nationally, the trends in cohabitating with their adult children. And we think that this is kind of interesting then, that we find a relative decline during a period when otherwise cohabiting with your adult children is becoming more common. And in fact, this is the more important trend in terms of the size of the trend than any sort of trend we see in the nursing home population. So my lower series there, my dark line, if you squint at it, there's a slight decline in nursing home rates, but it pales in comparison to the national trend of increasing cohabiting. So in conclusion, our take-home points from this research are that the BIP was not associated with any reduction in institutionalization based on our estimates, but it does look like there was a relative increase in the share of persons who are receiving supplemental security income, and that could be due to the reductions in cohabiting that we find. Now, what we think is potentially interesting here then is not necessarily the institutionalization results that we found, but instead exploring further these overall trends in cohabiting. And so when we think about our future research, one thing that we noticed is in our cohabiting models, some of the most important explanatory variables were actually our demographic variables. And we know that the elderly population is becoming more and more racially and ethnically diverse. And it looks like there are very different norms in terms of cohabiting. And so just that gradual diversification itself may be explaining some of what we're seeing. And then finally, we're also really interested if this is a story about changes and substitution of publicly provided home and community-based care for care that would have otherwise been provided through cohabiting with adult children. We're wondering whether or not there are spillover effects for the labor supply of people who would have otherwise been informal caregivers. So with that, thank you so much for your attention, and I'm very much looking forward to hearing some of the comments from our discussants.
Hi, this is Helen Levy from the University of Michigan. I'm the first discussant for this paper. So thank you, Mary, for that excellent presentation. Hallie, would you mind advancing to the second slide, please? So just to provide a little background to place this intervention in context, the figure on this slide, which is borrowed from a CMS report commissioned by the Center for Medicare and Medicaid Services, this shows the share of Medicaid expenditures for long-term services and supports that have gone to institutions, mainly nursing homes, that's the blue line, versus the share of their long-term spending that has gone to home and community-based services, which is the purple line. And the graph starts in 1980, and you can see that Medicaid's original role in paying for care for individuals with disabilities was really entirely to pay for nursing home care. And over time, the focus and spending have shifted away from institutional care. And as of 2013, the mix of institutional versus home and community-based services for long-term services and supports in Medicaid was at 50-50. And there have been multiple motivations for this shift. So one is the idea, advanced in the courts, among other places, that individuals with disabilities have a right to be supported by Medicaid in a community setting if that is consistent with their needs and preferences. And then another idea that's in the mix and is a motivation for this shift is the one that Mary mentioned at the outset of her presentation. And that's the idea that nursing home care is really expensive. And maybe the Medicaid program could save some money by keeping people out of an institutional setting. So in some cases, it can be a win-win to keep people living with support in the community rather than in a nursing home. Hallie, could you advance the slide, please? So an important question about this shift over time in the way Medicaid pays for support, long-term services and supports. An important question is, so can Medicaid keep people out of nursing homes, out of institutions, by devoting more resources to home and community-based services? And this is a very hard question to answer, in part because this spending and these outcomes, like the share of Medicaid beneficiaries who are institutionalized, evolve together over time in response to underlying demand factors. And it's very hard to disentangle in the data what is causing what. So just to illustrate the difficulty, suppose you have an underlying shift over time in how healthy your population is. For example, you have lower rates of smoking in more recent cohorts, and so those cohorts age with fewer limitations than their parents did. Then you will have fewer people institutionalized and probably more spending on home and community-based services, and you're going to see that correlation in the data over time. But you can't infer that it's because of increased spending on home-based services that fewer people are in institutions, rather than a response to the underlying shifts in demand. So that's why it's hard to say what is, what's causing what, and that's where the balancing incentive programs offers a real opportunity. Next slide, please, Hallie. Because in the case of the balancing incentives program, what we have is a policy that clearly affects some states and not others. And the states that were not eligible for the policy and the bump up in spending from Medicaid presumably were affected by the same underlying trends, such as the changes in smoking rates across cohorts in the example I just mentioned. But they didn't have the shift in their HCBS spending that the states that did participate in the balancing incentives program would have had. So that means that this provides an opportunity to disentangle, what happens when you increase spending on home and community-based services. What does that cause to happen, independent of these other things that are changing over time? And so the analysis in this paper uses that experience in particular, uses the states that were not eligible for balancing incentives payments, the increase in payments because of the balancing incentives program, uses those states as a control group to isolate the effect of the shift in spending on different outcomes. Next slide, please. And so that's what the paper does, and it does so quite convincingly. So for example, the authors demonstrate that the trends in the various outcomes they look at in the paper prior to the balancing incentive programs were moving in parallel, which supports the idea that the underlying factors, again, this is the things like smoking, that if those factors were changing, they were changing in the same way in the states that participated and the states that were not eligible. And the outcomes that the authors look at are living arrangements among individuals ages 65 and older. So are they in an institution or not? Are they co-residing with family or not? And did they move in the past 12 months? And also receipt of supplemental security income. Were people getting SSI benefits? And if so, how much? And of course, that matters because it potentially offsets any cost savings associated with reducing nursing home spending. So the analysis shows, a little bit surprisingly, that there's no change in the fraction of older people who are in institutions, but that there does seem to be a relative reduction in co-residents. And remember that in this context, that means a smaller increase compared with the non-participating states. And consistent with this, there's not a significant change in how many people are getting SSI, although there is an increase in the average benefit that people are getting when they get benefits. So this scenario is entirely plausible. Picture a widow who's been living with her adult daughter, and a new program comes along that will have an aide come every day to fix her lunch, make sure she's taking her medications, and make sure she's okay. And she moves out and gets her own apartment. Hallie, could you advance the slide, please? And this scenario, which is, illustrates the type of thing that empirically this paper finds, this is consistent with a somewhat old but still very interesting literature that looks at what Social Security and other income support programs for the elderly have done. And one consistent finding from that older literature is that it allowed widows to get, to paraphrase Virginia Woolf, an apartment of one's own. So it enabled older widows to live independently of their adult children. And so I would suggest for future analyses that the authors should look at differences by gender and marital status, in addition to the sub-analyses that you currently have in the paper where you're looking at the results by income groups, by age, by disability status. The final comment I would make is that the paper is a little bit of a black box in terms of what the policy intervention was. So it's essentially a 0-1 decision. Does a state participate in the balancing incentive programs or not? Going forward, I think it might be helpful to think about state spending on home and community-based services as the policy lever that states have. They're not going, they're not at this point deciding should we participate in the program or not. They're deciding should we shift the mix of spending that we have. And so thinking about taking the estimates and constructing some measure of, if a state shifts their spending, what does that do to the outcomes for the people in their state, and using the experience of the balancing incentive programs to get that kind of a parameter might be more useful going forward for policymakers. I will stop there, but just to summarize, this is a very interesting and careful paper with policy relevant results, and I think it also raises other very important questions for future research. Thank you.
Thank you, Helen, for those comments, and Mary and your colleagues for the interesting study. So I'm going to also let Hallie advance my slides. So my history and role here is to kind of take a look at the nearly 40 years of long-term care policy work I've done and apply that lens over the study results as well as some of the questions that I raised. So click ahead. One of the things that I would say is that long-term care is really complex. If you hadn't already looked at the study and asked yourself the questions on some of the controls and outcomes, I have even more to share with you. And so my first job is to kind of say, there are incentives that individuals, because as you know, how you purchase long-term care, where you receive long-term care is a very individualized decision regardless of where you live and which state you live in. I will say that Minnesota, one of the 40 years ago when I started getting involved, Minnesota, where I'm from, had a really high ratio of institutionalization compared to the rest of the country. And over the past 4 decades, instituted all types of rebalancing programs and incentives, and now we have one of the lower rates, to the point where we're looking and questioning whether or not access has become an issue for us. But as I said, it's really a personal decision. And in there, I've delineated just here some of the specific questions that arise for individual families as they're making the decision what to do. So in addition to earlier comments about, widows, if you don't have any family members, even if you do have family members, there is the question of how much family members are going to be willing to provide for free. If mom or dad lives with you and you are working full-time and you're in the sandwich generation and taking care of your kids, there's going to be a limit to the amount of services you're going to be able to provide and how many times you'll have to take off work to take mom to an eye doctor appointment, a dentist appointment, a lab appointment. So I think we have said for decades that it's billions of dollars of free care that family members give, and we want to make sure that we don't lose the care that the government programs don't have to pay for right now because families step in to do the work. So the question here is whether free services can easily be complemented by what we call the formal services or paid caregiving, paid services, whether those services are in your home, in a nursing home, in an assisted living, or a different environment. We do know that there is a limited availability of both informal and formal caregivers. So the example I gave earlier about the sandwich generation, there are significant costs, and business enterprises have gathered a lot of data about their lost productivity time related to caregivers needing to leave work to take care of mom. Mom fell, you got to go home. There's a new emergency, and you're going to have to be going to doctor's appointments. Your mother has advanced dementia, you'll be taking an extended leave. So some of those real-life examples are true costs to the labor market. And I will also show you a slide a little bit later on the second point, which is the formal workforce shortage is pervasive. It's across the whole country, whether it's rural or urban. And if you don't have the caregivers that can come into individual homes, congregate care is the latest trend. And so again, it goes to the point of access. If you don't have access to individuals to come into the family home to supplement, or to individuals' home to add additional services, that becomes an issue. Seniors' contributions. Many studies have been released about the savings rate declining and people being prepared, or rather ill-prepared, to pay for long-term care expenses, which means that fewer and fewer seniors are going to be able to contribute privately to any of their long-term care expenses that are not covered by either Medicare or supplemental insurance programs. The seniors' financial contributions impacting qualifications for other programs. So under the Older Americans Act, there's a variety of other programs that are either income-based or, depending upon which waivers the states have applied for, individual states have a variety of programs that offer Medicaid waiver benefits above and beyond the threshold for Medicaid. So in some states, similar to Minnesota, we have a tier of individuals who are not very well off, but they don't meet the qualifications income assets for Medicaid, yet they are qualifying for similar programs. So I think that's also critical. And as I said, access is a driver. So under many home and community-based services programs, as you know, they do not pay for housing, they pay only for services. If there are no affordable housing stock, that will drive where people live. If they can't afford to pay their rent, whether the services are covered under Medicaid or privately, if there's no place for them to live that's affordable, that also becomes a driver. This last bullet point on financial exploitation considerations, I just added there because that was a thought that has come to mind as we are looking at some of the national stories that are coming up about exploitation and whether or not there's incentives for family members who are poor to help their family members live with them in order to be able to keep some of the money that comes to that individual senior. So if we could advance it one, I'll reference the slide on the future changes in care delivery. So this is, everyone knows these generations. I stopped at Generation X because the next generation isn't going to be doing caregiving anytime soon. But the message for this is, you know what, we are going to have a crisis on the ratio of caregivers to care receivers. So again, as you look at individual service needs of seniors and needing home care, needing whether it's nursing, skilled nursing, medication management, homemaker services, home health aid, all of these formal paid caregivers, the ratio is just not going to be there as we look ahead. And I think that will eventually become one of those drivers that even if you have balanced programs to change the dynamic of where services are mostly delivered, this has to be an issue that is addressed by states. Advancing the slide, please. Other considerations. So as I said earlier, If you have folks without means, the Medicaid program only pays for services under home and community-based programs. And the definition, I think, is assumed that it is in people's homes. However, in states like several of the states, home and community-based services can be generated in assisted living settings. And because of the levels of care in some assisted living communities, the lines between nursing facility setting and assisted living settings gets a little bit blurred, especially if you look at the costs to those different settings. The more services are added in assisted living, the more it looks like a nursing home. So in the future, when you use the moniker home and community-based services, I think there needs to be clarity on what exactly we mean by that. Variations in what's considered institutional versus home and community-based services varies across every state. So assisted living, residential care, independent living, senior housing, all of those terms are not used the same on a state-by-state basis. So as your future research needs to measure kind of the description of what the setting is. Basically, the last bullet point there on service availability is complex comorbidities means increasing cost per day, and we have a increase in the number of individuals with varying dementias, which is an additional consideration as you look at where care is delivered. Cultural variations, Mary noted a bit of that at the end of her presentation. We do know there's an increasing diverse 65 population where multi-generational living is prevalent and expected. And so that is something to keep in mind. I think immigration policies today are affecting some current practices, both in terms of workforce and informal caregiving roles. And then the last point on social determinants of health. In some cultural communities, as we are finding, the poorer the population, the greater the likelihood that when they enter the long-term care formal system, they will have much heavier care needs and at an earlier age. And so that's another issue that we've been looking at here. Moving on to the next slide, demographic considerations. And these are all interesting facts that all could be converted into great research questions. So I'm so glad to see that Mary and her group are interested in pursuing some additional research in these areas. So there is the study here focused on the over 65 population, but there is a greater increase in under 65 populations that are frankly residing in both nursing facilities, nursing homes, and structured assisted living settings, partly because of policies that drive payment for mental health and chemical health, as well as the prevalence of early onset dementia. So we are seeing an increasing numbers, especially in nursing homes, especially in rural communities where there are no other placement options for the services. We are seeing an increasing in numbers of solo seniors. We don't call them widows, widowers. Minnesota, we call them solo seniors, meaning they don't have friends and family supports. That's a big issue. The at-home supports, meaning that if people are staying at home for longer until the point where the informal caregivers can't put together a whole system of support to keep them there, we are finding that the advanced age and infirmity of those entering the more formal system of care is ever increasing. So average age in Minnesota of an individual entering an assisted living program is about 88, and they stay for about 18 months. So I think there's some research questions involved there, and I mentioned the labor shortage. Payment system considerations. We do know Medicare doesn't pay for a lot, right? And we do know that it doesn't essentially pay for long-term care. With the changes in the administration's look at Medicare Advantage plans, we may see that changing in the future. So it's a little difficult to continue to study when we have all sorts of changing, swirling policies out there, but that's kind of what's going on. Medicaid coverage restrictions, I noted earlier, Medicaid does not pay for the housing of people outside of nursing homes. And so how do you make sure that as you compete for affordable housing with families, that you have affordable housing for seniors available? And I did mention there are implications for those just above Medicaid eligibility. The last slide I have is really a slide that shows that the Minnesota experience on age. Again, I'm showing that we do have a very significant population of individuals, 42% in Minnesota, that are receiving some long-term services and supports, essentially home and community-based services or nursing facility care, or support grants or something. That is a high percentage, and even though the population itself reflects that, we've continued to be surprised at the individuals in their early 60s that are receiving care in our settings. So with that, I think I rambled and gave you all sorts of examples of additional studies. I'm fascinated by the potential on this kind of work and turn it over for questions.
Thanks so much. Thanks to everyone for your presentations. And now we do have some questions that have been posed by our audience. And I do believe that Mary's co-authors are on the line to step in and answer some questions. That's Daniela Hochfellner from NYU and Brooke Helpy-McFall from University of Michigan. So to begin with, Mary, I'm going to pose a question to you that's just a little bit of a clarifying question. And this really, it came up as Patty was speaking as well. So she brought up the differences from state to state in how home and community-based services are defined. And so what I'm wondering is, for the BIP program, was there a definition that was used across states for uniformity's sake? And if so, can you just provide that so that we can all be clear on exactly the type of services that we're talking about?
Sure, Hallie, I would be happy to speak to this question. And this is a really challenging thing, I think, for all research in this area when we want to do things that are across states, because as Patty mentioned, if we have different definitions across states, it's very, very difficult to tease out what's going on. Unfortunately, that kind of leaves us with a fairly blunt measure, which is the one that we used, which is the group housing definition, which is in the American Community Survey. So we are using the variable that defines whether or not individuals live in group quarters. This is a little bit challenging as well if you want to do analysis, say, across 2 years for the same state, because there are some changes in group housing definitions over time that the census has implemented. And so that's why it's so important in studies like ours that we do have a control group. But what it doesn't allow us to do is to dig into whether or not some of what we're seeing in the increase in living outside of an institutional setting might be in things like these assisted living facilities that Patty has mentioned, that increasingly can provide levels of care that maybe are approaching what we might see in a skilled nursing facility. Our understanding, based on reading through the census manuals on that data, is that the persons who we are counting as institutionalized are only those who are living in skilled nursing facilities. But as researchers, this has been one of the more frustrating limitations as far as what we can do with data that spans all states.
Very good. And so I have a question that I'm going to just throw to you in the same kind of realm, Mary, and then you can pass it off to Patty for some, maybe some more context, or she can add to it. But so you were speaking at the beginning of your presentation about how there were some states that have these really low or much lower expenditures in the home and community-based services. And so we're wondering, were you able to hone in on any kind of underlying issues that those states are grappling with, or any kind of root causes of why certain states really are underspending in that area? Is there, deeper poverty, or is it a different population makeup in those states? Like, what can we view as one of the underlying causes of this discrepancy between states and their spending?
Sure, thanks, Hallie. What I can say is there are some fantastic case studies that were done on the BIP, and my colleague Danny may have something that she wants to chime in with here as well, perhaps after we allow Patty to add some of her context in Minnesota. But there could be fairly complex reasons why states may choose not to participate in the BIP, or why their rates were lower in the first place. As we know, there are lots of different waivers that states can use to provide home and community-based services or services outside of the nursing home. If they don't have a waiver in place, then there are restrictions on the way that they may spend their Medicaid dollars on long-term care services that essentially biases, this is known as the institutional bias, it biases them towards spending those monies on nursing home care. And so what we're really looking at then as far as initial differences in spendings are what waivers the states participated in. So I'll let Patty jump in for a minute, but then we should circle back around to my colleague Danny, because part of this project took a rather deep dive into the sorts of waivers that states had in place and trying to compile a lot of this information into a database. But Patty, please.
You know, I think you said it all. It really, for much of the country, it's a political decision, because the waivers the fear is the woodwork effect would occur. That if you have home and community-based services that are going to be government funded, then you would not get the family informal caregiving. And so there are some states that, because they have to do the state matching, have chosen not to fund any waivers, or have chosen to have some strong limitations to the types of waivers that they have applied for. And or they may have set the level of care criteria so high that qualifying for those waivers is extremely difficult.
Danny, did you want to add at all?
Yes, I can add a little bit. So what we've done is, in order to address these questions, because it was very hard for us to kind of get a sense of how different states approached kind of this implementation of the BIP. We've collected a lot of outside resources of what has been going on in the states before and during the period. We looked at all these different waivers, of the content of the waivers that some states were already applying for, which gave them already some money to spend in some settings, but not other settings. And so this is why some states might have chosen different strategies. And then the case studies that Mary mentioned, the case studies, they walk you through how different states implemented these, and where the focus were, as we've heard before, it was not only older people. So older people, some states, they focused on the older people. They had different strategies, different spendings, and different ways that they would implement the requirements of the BIP, whereas states that would more targeting the population that is disabled, for example, and need help. So there's a lot of combinations, and what we've done, and maybe this is more helpful than because it's very much to talk in. Now we don't have that much time, right? But we have collected all the data, and you can access the data on each state, where we give you more input on what was going on at the state in the time around where the BIP was implemented.
That's very helpful. Thanks so much for that background, Danny, and thanks for weighing in on that as well, Patty and Mary. I have one last question that I'm going to pose, even though we are a little bit short on time, but I just want to squeeze this in there, and I'm going to pose it first to Helen, because I feel like maybe she can weigh in on this or provide some updates, and then Helen, feel free to pass it on to Mary or one of the research team. But what I'm wondering, or what our audience is wondering, are so this is a pilot that has ended. Are there any updates to this program, or any future possibilities for this program, or has there been any policy changes that have occurred because of this pilot, or any implications for policy in general?
Oh, that's a good question, and I don't know the answer. I don't know if there have been subsequent enhancements to the federal match to do this kind of rebalancing. As Mary mentioned at the outset, the goal of this program was to bring up the states that were had been the slowest to shift their spending. And it did largely succeed, but it's possible that Patty would know this, whether they've had subsequent, essentially bonus programs to the federal match rates to try to get states to keep going. Patty, do you happen to know that?
Actually, it got buried in the expansion of the ACA debate a little bit. So I think instead of bonus programs as the BIP was, the deregulation and the giving greater flexibility to states has been the latest mantra.
Okay, I'm going to have to end it there, but I really appreciate all of the presenters today. I'd like to thank Mary Hammond, Daniela Hochfellner, Brooke Helpy-McFall, Helen Levy, and Patty Cullen for your contributions today. And thank you to our audience for tuning in. As a reminder, this webinar was recorded, so it will be posted on our website in the next day or two. You'll also receive an email following up with that recording. So I'd also like to point to another event that's taking place later this month, October 23rd. We have a webinar titled, What Motivates Consumers to Check Their Credit? Evidence from a Field Experiment. So please look for registration details on our website, as well as emailed invitations that are going out this week. Again, thank you to everyone, and enjoy the rest of your day.